Welcome to our second lesson in the POCUS for Women's Health series, which is going to be focusing on ectopic pregnancies and how we can utilize point of care ultrasound to help diagnose them or make them less or more likely. As a review, in our last lesson, we talked about some of the first trimester ultrasound findings that we'd expect to see in a typical pregnancy. We talked about indications and how to perform the scans. We talked about the expected ultrasound findings that we should see based on the estimated gestational age. We talked about diagnosing and dating an early pregnancy and used the crown rump length to help us do so. We talked about measuring fetal cardiac activity using M-mode and how the presence of fetal cardiac activity portends a positive prognosis for an IUP. We established IUP viability and talked about some of the findings that can suggest or diagnose a failed or failing pregnancy. And we discussed briefly some of the medical legal considerations important to first trimester ultrasound. So today, we're going to be focusing on the use of point of care ultrasound in patients who we suspect might have an ectopic pregnancy. Let's start with a piece of evidence very first that's important to remember. The most common ultrasound finding in patients with a diagnosed ectopic pregnancy is a normal ultrasound. So while we can certainly use this tool and there's some findings that may help us make this diagnosis, if our ultrasound is negative, we cannot rule out an ectopic pregnancy. So remember that this is a rule-in test, not a rule-out test for these patients. I like to say that the risk assessment is greater than the scan findings. That's another way of saying that this is a rule-in test, not a rule-out test. It helps underscore the basic principle of POCUS for ectopics, which is that risk assessment is often more important than the findings on the scan for determining what the next step in management should be. This is a meme I found online. I stole it from the internet, so ignore the typo that's in it. It's somewhat worrisome that a professor or some medical professional made this, but maybe they were post-call, not really sure. But once again, adequate evaluation of an ectopic pregnancy is equal to an adequate assessment of the risk, and that's integrated into the clinical scenario in which the patient is being seen. So, you've seen this slide before, and you'll probably be tired of it, but you'll never not see it. POCUS is a tool to answer a focused clinical question, not a full imaging study. In this case, the clinical question is really a set of two opposed clinical questions. The first is there sufficient evidence to diagnose an ectopic pregnancy? This carries the implication of escalating care and intervention for the patient, whereas the other is carrying an escalating risk that could be disastrous if the wrong conclusion is drawn. And that second question is there sufficient evidence to rule out an ectopic pregnancy? In reality, the usual truth in the clinical scenario for a point of care evaluation lies somewhere in between these two questions, because we often don't have enough clinical evidence on our exam to definitively answer either of these questions, which limits the efficacy of a point of care ultrasound for this purpose. A key takeaway, in any patient that's pregnant, an ectopic pregnancy should be suspected if you don't see an IUP. Another way I've heard this put is that all pregnancies are ectopic until proven otherwise. Although all pregnancies should be considered ectopic until proven otherwise, there are some findings on history and physical exam that do make ectopic pregnancies more likely. To use our doctor words, we can use these risk factors to help estimate our pre-test probability. So why is risk important and why is our pre-test probability important? Let's use this as an example. Patients who come in that are symptomatic and have a positive pregnancy test have a 2% chance, based on population studies, of having an ectopic pregnancy. And that chance rises to about 8 to 10% for patients who are being examined in the emergency setting. Now, if we are able to use POCUS and see an intrauterine pregnancy that appears viable, that portends a likelihood ratio of 0.08 for an ectopic pregnancy. So if we use our nomogram over here and we start off by saying, okay, my risk if I'm in the ER in some critical access hospital in the future, some rural ER, is 10% at the highest estimation that this patient could have an ectopic pregnancy. They come in, they're spotting, they have a positive HCG. And then I throw that ultrasound on and I see an intrauterine pregnancy with cardiac activity, and everything looks reassuring, there's a good decidual reaction around the gestational sac, the fetal pole is present, all that good stuff, and I use that 0.08, that takes my risk then for post-test probability of this being an ectopic pregnancy less than 1%, which is usually sufficient to discharge these patients with adequate close follow-up. So that does change our management if we are able to visualize an intrauterine pregnancy. But in the case where we don't see those definitive findings, this isn't so helpful. So it's important that we understand our risks and what our patients are coming in with and what the chances are they could be having this diagnosis to be able to adequately assess them using point of care ultrasound. So the first clinical question that we can ask is there sufficient evidence to rule out an ectopic pregnancy? And there are a few criteria that have to be met for this. The first is that we need to see a visualized gestational sac with a yolk sac or fetal pole, and that this sac has to be located definitively inside the uterus. Another metric that we can use is seeing 5 millimeters of myometrium that surrounds the gestational sac, which helps further prove that yes, indeed, this pregnancy is located inside the uterus. And then to make sure that we're using an average risk patient, they can't have a history of using assisted reproductive technologies such as IUI or IVF to help establish or conceive this pregnancy. Just because the risk of heterotopic pregnancy or multiple pregnancies or multiple gestations rather, is so much higher in those patients that this screening tool does not adequately lower the risk so that we can rule out a pregnancy or rule out an ectopic pregnancy. So this is our first question, and very, very rarely are we going to be able to apply it. But when we do, for low-risk patients, visualization of an IUP does effectively rule out an ectopic pregnancy. Now, some of you may be thinking, well, what about heterotopic pregnancies? What about that clinical scenario that we all worry about in medical school? It is true that that is a risk. And I can't say that this risk ever goes down to completely zero. But based on those findings I showed you a couple slides ago, the patients who have not undergone assisted reproductive technology, and even more so for a patient who has no risk factors for ectopic pregnancies, the presence of a spontaneous heterotopic pregnancy is extremely, extremely low, effectively zero. So with that being said, know when you can apply this rule and when you should seek further clarification. You also have to know your anatomy and be confident in understanding it. For example, this patient was initially diagnosed with an intrauterine pregnancy, but if we look closely, we can see that this gestational sac, which is kind of rocketing through here, is actually not inside the uterus. So the uterus is up here. We have this intrauterine pole here, or this endometrial stripe here, and the fetal pole is located outside of the uterus in the adnexa. So this was an advanced ectopic that required surgical management to treat. So you got to be able to confidently understand what it is that you're seeing. Let's review our normal anatomy so that we can be confident in diagnosing these. So first of all, here's a transabdominal transverse view. We've got the anechoic bladder at the top here, represented in blue on this still image on the right. And then we have a circular or oval-shaped transverse view of the uterus deep to the bladder, represented in pinkish purple over here. And then this is a transabdominal sagittal view of a non-gravid uterus. We see the bladder here, the uterus coming up and curving up around, in this case anteverted, although sometimes you'll see those be straight or retroflexed. Once again, here's a review of what a transvaginal ultrasound will look like in the sagittal plane and in the coronal or short axis. So if we can't definitively diagnose an IUP in a low-risk patient to rule out a pregnancy, rule out an ectopic pregnancy, then perhaps we can tackle the second question. Is there sufficient evidence to diagnose an ectopic pregnancy? So to be able to definitively diagnose an ectopic pregnancy, we have to see a visualized gestational sac with a yolk sac or fetal pole, but in this case, located outside of the uterus. Now, this is a pretty rare finding. In fact, in all ectopic pregnancies, only 20% or less of them are going to have a definitively seen ectopic pregnancy existing outside the uterus. So let's go back to our example that we just had of the definitive ectopic pregnancy. So here we see a fetal pole here inside a gestational sac, but we also see a uterus with an endometrial stripe. And so we know that this ectopic pregnancy is definitively located outside of the uterus, and this is diagnostic or 100% positive predictive value of an ectopic pregnancy and demands active management. So if you don't see a definitive ectopic pregnancy, you'll probably see some sort of nonspecific adnexal finding that raises a suspicion for an ectopic pregnancy. Adnexal findings can be located inside the tube or outside the tube. They can be on the ovary, the broad ligament, on the bowel, and sometimes you'll see a clear circular gestational sac like the one you see here, and that can have this appearance, but note that how similar this appears to this normal finding in the left ovary, which is a corpus luteum cyst. Ectopics generally have a thicker and hyperechoic ring surrounding the gestational sac, and they're not surrounded by ovarian tissue, and that's how you can differentiate between a CLC and a potential ectopic pregnancy. More commonly, adnexal ectopics appear not like this good ring, but they appears as sort of complex, heterogeneous mass that's separate from the ovary, which is located here, but still doesn't really show much definitive detail in here, and it just raises suspicion that there could be something and not know exactly what it is. But in the presence of a positive HCG, it becomes much more concerning that this could be an ectopic pregnancy. So finding one of these findings, it has a positive predictive value of 88% in a patient that comes in with concern that there could be an ectopic pregnancy. One adnexal finding that's a little bit more specific and present in about 20 to 30% of confirmed ectopic pregnancies is the tubal ring sign. The tubal ring sign is an adnexal finding, and normally the fallopian tubes are poorly visualized structures that abut the uterus and extend laterally towards the ovaries. But when an ectopic pregnancy implants in the tube, this circular structure will develop that has a kind of iso or slightly hyperechoic ring surrounded by a relatively hypoechoic or anechoic interior. And this has a higher specificity and a higher positive predictive value for an ectopic pregnancy than other less specific adnexal findings. But there still are a few mimickers such as corpus luteum cysts, like we talked about, hydrosalpinx, that make the tubal ring sign not completely pathognomonic for an ectopic pregnancy. Another skill that's sometimes called upon in the world of point of care ultrasound to assess for the risk of an ectopic pregnancy is looking for free fluid in the pelvis, which usually represents hemorrhage in the setting of a ruptured ectopic pregnancy. To adequately assess for free fluid, we need both longitudinal and transverse views, and we need to put our curvilinear probe here on the patient's abdomen just above the suprapubic or just in the suprapubic region right above the pubic symphysis, and angle the probe up towards the patient's head for the sagittal view or towards the right for patients in the transverse view. We then fan through the pelvis, keeping our probe centered over the symphysis and tilted caudally to be able to visualize the pelvic organs. And what we see here is here's the bladder and our uterus, and here's the rectum. And this right between the uterus and the rectum is our rectouterine pouch, or the pouch of Douglas, where free fluid would collect. So there's no anechoic structures here, meaning that there's unlikely to be free fluid in the pelvis. So once again, here's where that pouch of Douglas would sit, where we could see some fluid if it was accumulating. If we do see free fluid, sometimes we can see it in the right upper quadrant as well, especially if the volume of fluid is very high, such as in an active or life-threatening hemorrhage in a patient that's coming in with low blood pressure and diffuse abdominal pain. This right upper quadrant view relies on seeing a gray sponge-like liver, a hyperechoic diaphragm here curving up ahead, and then the hypoechoic renal calyces where the kidney is abutting the liver. And in this Morrison's pouch, is where we see fluid collect when there's a large volume of free fluid in the abdomen. Here are a few examples of positive right upper quadrant FAST exams. So here we see the liver, it's sort of floating, and we can see rather than being nicely adjacent to the kidney, we see anechoic fluid surrounding the inferior tip of the liver, which represents a positive FAST. Here we also see a smaller amount of fluid, but we see some suprahepatic fluid. This may be some fluid here between the liver and the diaphragm, or it may just be attenuation of the liver. It's a little bit difficult to tell without being able to adjust the settings on our machine. But all of these represent positive right upper quadrant FAST views. So seeing suprahepatic fluid, which I would really put that up here. Fluid in Morrison's pouch, right there, or fluid at the caudal tip of the liver. All of these are positive right upper quadrant scans. Now, free fluid in the pelvis is a little bit harder to diagnose, but can still be seen. And we'd like to classify this as being mild, moderate, or large. So mild free fluid can be a nonspecific finding. It may be physiologic, especially in pregnant individuals. And what we mean by this is we see fluid that's contained to the pouch of Douglas, that's not extending all the way up the uterus. And this might be normal, or it could represent a hemorrhage. So it's not super diagnostic for our patients who are coming in with belly pain or with a positive HCG. On the other hand, patients who have moderate free fluid that extends from this pouch of Douglas all the way up to the fundus of the uterus is almost always pathologic. And this is really suspicious for hematoperitoneum and should warrant evaluation, especially in the setting of a potential ectopic pregnancy or ruptured hemorrhagic cyst. So lastly, we have large free fluid, which is fluid that extends beyond the pouch of Douglas all the way up to a positive right upper quadrant view, like we just discussed in our previous slide. So this helps us determine, if there's a positive pregnancy test, abdominal pain, hypotension, and this finding up here, that is definitively pathologic and warrants surgical exploration in any suspected ectopic pregnancy. So I just showed you several different ways to evaluate for an ectopic pregnancy. So let's put them all in one spot and review them and the evidence behind them one more time. The most specific finding is an extrauterine gestation with a yolk sac or fetal pole. So there is a pregnancy and it is not inside the uterus. That is 100% diagnostic of an ectopic pregnancy. But we only see this in less than 1/5 of all ectopics that present to the emergency room or to a clinic. Next most specific is the tubal ring sign. And while it's not commonly seen, if it is, it has a 95% positive predictive value that what you're seeing and dealing with is an ectopic pregnancy. More commonly seen, but less specific, is a complex adnexal mass. This could just be a corpus luteum cyst, it could be a hemorrhagic cyst, it could be ovarian malignancy, who knows? But it does raise the concern in patients with a positive HCG that there could be an ectopic present and should be further characterized with more imaging or surgical exploration. Now, the presence of fluid like a positive FAST exam, while it is predictive of a ruptured ectopic, is not necessarily predictive of a ectopic by itself that's not ruptured. And so the frequency for these is not really established well in the literature, and the positive predictive value for these findings is less specific. So the studies that have looked the most at FAST exams in ectopic pregnancies were pretty variable in their inclusion criteria, and that might be behind some of why these findings are not so specific. Additionally, FAST was designed for rapid assessment of trauma patients, and it's still being incorporated into the non-emergency medicine world. So this number may change as the field develops more, and providers like us use this assessment technique to specifically evaluate for ectopic pregnancies and their ruptures. So what about the beta HCG discriminatory zone? It's not reliable. So most studies in POCUS focus on the predictive value of a single beta HCG, usually using a cutoff of greater than 3,000, and the presence or absence of a visualized IUP to help determine what the risk is of an ectopic pregnancy. If you have an HCG that's above 3,000 and you look for an IUP and you don't see one, it should certainly raise your suspicion for an ectopic, but it is by no means diagnostic. As I mentioned before, HCG levels vary way more than we used to think they do, and there are lots of alternative diagnoses that need to be explored, such as gestational trophoblastic disease, multiple gestations, etc. A single POCUS exam should not be used in this case, and I recommend trending quantitative HCGs and repeating ultrasound exams as outlined in the ACOG Practice Bulletin number 191. So going back to our clinical questions we presented at the beginning of this lecture, in the case of ectopic pregnancies, the clinical question can be thought of as two separate competing questions. Is there sufficient evidence to diagnose an ectopic, or is there sufficient evidence to rule out an ectopic? And in reality, like we discussed, the usual truth lies somewhere in the middle, because we often don't have enough clinical evidence for our exam to definitively answer this question. Again, any pregnant patient, an ectopic pregnancy should be suspected whenever we don't see an IUP. And as a review, to answer question 1 and confirm an intrauterine pregnancy and sufficiently lower the risk of an ectopic to rule it out, we have to have a visualized gestational sac with a yolk sac or fetal pole definitively inside the uterus with 5 millimeters of myometrium surrounding the sac and no high-risk history of IVF or IUI or other assisted reproduction techniques which could raise the risk of a heterotopic or multiple gestation. Question 2, is there sufficient evidence to diagnose an ectopic pregnancy? Could include a visualized gestational sac with a yolk sac or fetal pole outside the uterus, but most commonly, we exist in this realm where there are features that may be suggestive but not diagnostic and warrant close follow-up or escalation of care for further evaluation of these patients.